Before we begin, I'd like to introduce the newest member of our team, the Director of Health Policy, Jeanette Contreras. Right, Jeanette? I'm trying my Spanish, my pathetic Spanish, but she helps me. But Jeanette goes by Jet, and many of you have already met her or worked with Jet. And as we look forward to collaborating with all of you, I'm sure you'll get a chance to get to know her and really appreciate all the talent and expertise she brings to this role. I'd also like to take a moment to acknowledge our diverse membership. We represent this member, the HAC has over 40 organizations from across the health policy spectrum. We so appreciate your continued support and engagement in the council as you help to foster partnerships and inform our consumer-focused work. So I'm going to turn things over to Jet now and look forward to a really robust, lively discussion.
Okay, thank you. Yeah, so a big welcome to our newest members, Amgen, MANA, a National Latina Organization. They were not able to join today at the last minute, but we're excited to welcome them. We're also welcoming the Emerson Clinical Research Institute and Latinos Against Alzheimer's. We definitely welcome the diverse perspectives within this membership, and so excited to work with all of you on a variety of healthcare consumer issues. And with my brief introductions, I'm going to moderate the panel later. I am going to turn it over to Nisa, our Associate Director of Health Policy, to give you an update on the Council's work this year. So she'll give you a snapshot of what we've been doing since our last meeting in June.
Thanks, Jet. Good afternoon, everyone. I'm Nisa. Before we begin, I'd like to go over a few housekeeping items. Please make sure that your devices are on mute, of course, and we suggest enabling speaker view so that only the active speaker is visible. If you have any questions throughout the program, please submit it through the chat box at the bottom section of the screen. And this morning or afternoon, you should have received a link to all of our program materials. We'll be including that in the chat box as well. And we welcome you to share any resources via the chat window throughout the program that you want to share with the membership. And for our updates since we last gathered in June, NCL has continued to advocate for consumer protections as in the realm of COVID-19 testing, health coverage, health-related fraud, and vaccine confidence. Throughout the fall, NCL has testified before the Food and Drug Administration and Center for Disease Control and Prevention in support of vaccine confidence, diversity in clinical trials, and emergency use authorizations for COVID-19 therapeutics. Additionally, NCL testified to support the reauthorization of the Patient Drug User Fee Act and the Generic Drug User Fee Act. We advocated for sufficient resources for the FDA to be able to have a rigorous drug review process. To raise awareness about the dangers of counterfeit drugs during the COVID-19 pandemic, NCL hosted 2 separate webinars in collaboration with our partners Pfizer and Eli Lilly. The webinars included consumer-focused messaging on how to avoid counterfeit drugs and measures that the pharmaceutical industry is taking to ensure the integrity of the drug supply chain. And in some exciting news, our consumer drugs platform, counterfeit drugs platform, FakeRx, recently went through a redesign, and we invite you all to visit the site and see the updates, as well as share it as a resource among your networks. To address consumer fears regarding the expedited approval of a COVID-19 vaccine, NCL held a briefing with Commissioner Hahn of the FDA. Commissioner Hahn reassured consumers that the FDA will only approve a COVID-19 related therapeutic using a measured evidence-based approach. And like Jeanette mentioned, or Sally mentioned rather, this morning we gathered with the CDC and FDA to host a COVID-19 vaccine Q&A in conjunction with Vaccinate Your Family about this issue as well. We've also convened industry stakeholders like the American Clinical Lab Association and the Quest Diagnostics to address the state of COVID-19 testing and the steps being taken to ensure adequate testing across the country, access to testing. On the CBD front, we have been active in addressing health-related fraud about the potential dangers of unapproved CBD products. In October, NCL participated in a panel hosted by Third Way, which is a national think tank, where we shined a spotlight on NCL's white paper that dealt with CBD direct-to-consumer marketing and the research as marketing trend. And in November, NCL met with FDA's CBD policy working group to discuss the importance of furthering FDA regulation on CBD products and to call on the FDA to enforce existing regulations for labeling and ingredients. We were joined by the Centers for Science and the Public Interest and the Consumer Federation of America. And my final update is that our landmark medication adherence program, Script Your Future, is turning 10 years old in 2021. Every year, the Team Challenge convenes pharmacy schools from across the country to form interdisciplinary teams to foster medication adherence values. We will be kicking off the challenge in February of next year, and we just ask that you please stay tuned for additional details in the coming weeks. That concludes our updates, and I'll call on Jet to introduce our panel and kick off the discussion.
Okay, great. Thank you, Nisa. Yeah, I have to give Nisa a lot of credit this year for holding down the fort before I came on board, and to say that she's done a great job. And I am, still playing catch up, I think, in my new role. But definitely, Nisa, thank you, Nisa, for helping to bring me on and make me feel welcome here. We wanted to have this discussion because in light of COVID-19, we really have, we're trying to focus more intentionally on addressing health disparities in our health portfolio work. We definitely want to ensure that our most vulnerable consumers have a voice during this pandemic. So that's why we wanted to have this discussion today. Definitely because we recognize that low-income and minority communities hardest hit by the virus continue to disproportionately lack access to adequate testing and experience more severe COVID-related illness requiring hospitalization and are at greater risk for death from COVID-19. So we are thrilled to be joined today by Dr. Martha Dawson, an associate professor at the University of Alabama at Birmingham School of Nursing. She's also serving a 2-year stint as president of the National Black Nurses Association, who is an advocate for some of our most essential frontline healthcare workers. The mission of NBNA, the National Black Nurses Association, is to serve African American communities, increase the number of African American nurses, and improve equity, equality, and inclusivity in health education, service, practice, and research. We are also joined today by Dr. Linda Fu, who we've heard wonderful news from today so far. Currently, she's the Director of Academic Development for Community Pediatrics at the Children's National Health System in Washington, D.C., she's dedicated her career to improving the health and well-being of children with a keen focus on children from medically underserved communities. So Dr. Fu is currently a member of the American Academy of Pediatrics Global Immunization Project Advisory Committee, which helps to address patient vaccine hesitancy across the world. She also serves as the chair of Immunize DC, one of 3 stakeholder organizations identified by DC Health to advise them on their COVID-19 vaccine distribution and communication strategy. Finally, we're joined by Dr. Fabian Sandoval, CEO and Research Director for the Emerson Clinical Research Institute, who has created a successful model for conducting community-based clinical research while caring for low-income and uninsured patients in the greater Metro DC area. Dr. Sandoval has participated in federal and congressional briefings focused on ensuring minority patients are adequately represented in clinical research studies across the country. Through its foundation, the Emerson Clinical Research Institute educates physicians and minority patients on the importance of participating in clinical research. We are really honored to have all of our panelists here. They've certainly dedicated their careers to addressing health disparities in their communities. And we're going to start off today's panel with Dr. Fu. Dr. Fu, if you want to go ahead and start sharing your screen. She's going to give us an overview of the state of vaccine confidence in the US and tell us about her work on addressing vaccine hesitancy among communities of color.
All right, thank you, Jet. Can you all hear me? Okay, great. I didn't realize everybody was listening earlier and could hear all of that. That's the pleasures of Zoom. So, and also I can't see the chat while I'm sharing my screen. So if there's any questions, I'll look at them at the end. So as Jet said, I'm going to start us off just by giving us an overview about COVID-19 health disparities, and then what I think are some of the implications for communication amongst people of color. And so I was asked to focus on children since I'm a pediatrician. The same way that we've been hearing about health disparities amongst adults in COVID-19 morbidity and mortality, that is reflected in a differential also in children, which we don't hear about as much because luckily children aren't as severely affected. However, the CDC reported between February and July, the latest data that they have released, 121 deaths in children. And I just kind of put it on this graph to demonstrate what you can really see is the differential. So the blue bars are the percentage of the population, the US population, that belongs to each demographic, and the red is the percent of the deaths. And as you can see, amongst white children who make up close to 50% of the US population, they make up 20% of the COVID-related deaths. And so the blue bar is higher than the red bar, but for Black and Latinx and American Indian children, that differential is reversed. So definitely Black, Latinx, and American Indian children are disproportionately being affected by COVID-19 mortality, as we have also seen in adults. So what are the reasons for this? I think that we have heard, and there has been studies coming out, and the timing has really overlapped with the Black Lives Matter movement. People of color are disproportionately being represented amongst essential workers. Of those who work in food and agriculture, 50% are either Black, Latinx, or Asian. And then 53% of the total in industrial, commercial, residential facilities and services are also people of color. People of color are also overrepresented in high-density urban areas and neighborhoods. They also tend to live more commonly in multi-generational families. And then, of course, due to historical and systemic racism and issues, they have lower access to quality housing, transportation, healthcare, and education. And of course, that all ends up coming together as explanations for why there's disparity in COVID-19 morbidity and mortality. So numbers, I think, are helpful, but what I think I've really come to appreciate in my own research is the benefit of qualitative research and really listening to what people are saying. And so back in August, my team and I did some qualitative interviews of Black parents from our health center. We had 30 parents and we asked them a variety of questions, but in particular for this talk, I thought it was helpful to think about some of the disparities-based barriers, race-based disparities barriers that they've mentioned to wanting to be tested for COVID-19. So one of the themes was privacy concerns, and a quote was, "I don't trust the government and I will keep saying that. I don't feel like they should know my test result because I feel it's a control thing." We talked about earlier current and historical mistreatment. One participant mentioned in the beginning, I thought it was unfair to most African Americans because our testing spots was very limited. And that was shown to be true. And so it was very, I thought, observant of a comment, and it helps to reinforce this feeling of disparity. And then, of course, historical mistreatment. I'm thinking about the Tuskegee experiment and things like that, in which African Americans were used in a wrong context. In some people, it led to, I would call, a sense of fatalism, and then, unfortunately, less healthy beliefs and attitudes. When it came out saying that African Americans are more at risk at having the coronavirus than whites and Asians, it's not surprising to me because we're always in the negative light in the media, and half of the time it's not even the truth. So if you don't actually believe that your race may put you at increased risk for disease, then why would you get tested? Also, when you don't trust the healthcare system, when you have a Black patient saying that they have all these symptoms and the white doctor isn't taking it very seriously and whatnot, why should I even worry about getting this test or whatnot? So what does this mean for COVID-19 vaccine uptake in communities of color? As you all know, there are vaccines that are in EUA at the FDA or will soon be in EUA. So, and then in terms of pediatric trials, Pfizer is undergoing EUA review for ages 16 and plus, and the vaccine is 95% effective with no serious side effects per press releases. And they have started safety trials in ages 12 to 15 years. Moderna will soon submit for EUA review for adults, and they have reported in their press releases 94% effectiveness with no serious side effects. And they announced on a few days ago that they will begin safety trials in ages 12 to 17 years. AstraZeneca has already started safety trials in the UK for ages 5 through 12, and they and Johnson & Johnson have announced that they will they intend to start trials in children. According to clinicaltrials.gov and the WHO listing of trials, there are 3 trials in China enrolling participants as young as age 3, and 1 trial in India enrolling ages 6 and up. So things are moving along in the vaccine development realm. However, as we like to say in pediatrics and in vaccine promotion, it's not vaccines that saves lives, but it's vaccinations in arms that save lives. So this, these sets of polls from the Pew Charitable Foundation is actually pretty distressing, in that when they polled the American public in May of this year, they found that 72% would definitely or probably get the COVID-19 vaccine when it was available, whereas in September, that number dropped to 51%. And you can see it dropped amongst all demographics, but particularly relevant for this talk is that only 1 in 3 Black Americans would accept the COVID-19 vaccine. And that ratio has been repeated in other polls as well. It's particularly distressing because based on various biological and behavioral factors, how much we actually socially distance or not, the threshold for COVID-19 herd immunity will be 55 to 82%. And when you think that children will not be eligible for getting vaccinations, and they make up 1/5 of the US population, we really need a lot more people to accept the vaccine. And what that means in areas and neighborhoods, which are predominantly neighborhoods of color, it needs to be in that community. So having an overall national rate of 82% is not sufficient to protect somebody living in a community whose rate of uptake of the vaccine is only 30%. So what are some potential solutions? As we all know, that patient education from healthcare providers is very effective. It's necessary, but I would not say sufficient to get people to accept vaccination. But, you know, in relation to COVID-19, patient trust in their healthcare providers still bears out. When asked, who do you trust the most to handle for the COVID-19 outbreak, you can see across all races, doctors and hospitals were very high amongst the trust level, and that has stayed consistent throughout the pandemic. This group looked at other people, including politicians and, you know, community-based organizations, whatnot, and the level of trust to handle the coronavirus outbreak was much lower than doctors and hospitals. So training of the physicians and how to give strong, and of nurses and of ancillary staff to help give strong COVID-19 vaccine recommendations will be critical to ensure uptake of the vaccine. But it's not enough, as I alluded to earlier. We need to engage cultural leaders as partners in this endeavor. And so I'm sharing a hard to read slide from one of my studies, and where we asked 100 Black parents who they trusted for vaccine advice on a new vaccine. And as you can see here, this level is the median. On a scale of 1 to 10, families trusted the CDC scientists and pediatricians very highly. However, they seem to trust race concordant, so other Black pediatricians, more than they trusted ones who were not race concordant when they were shown representative examples. And so actually, they trusted other parents, other mothers, and other disease survivors as highly, if not more highly, if they were race concordant as opposed to a race discordant pediatrician. So, you know, we all tend to gravitate to people who we think share a similar world outview as our own. And so it's very important to have people who everybody can relate to in order to reinforce the message that people receive from their physicians. And so that's why I was so happy to see the announcement that two presidents from historically Black colleges and universities, from Xavier and, from University of Louisiana, said it's important to have people like us in these trials. So they joined COVID-19 vaccine trials and encouraged their students to do the same. And unfortunately, they actually received some backlash for doing so, but it was very brave of them to do that, and so important, incredibly important for them to take that stand and show that they are investing in this and that the trials are not for white people, they're for everybody, and it's important to have that safety and efficacy data for people of all races. Which brings me to the point of equity. Many of you are familiar with this graphic. Equality means giving everybody the same thing. Equity means giving everybody something that they need. And then justice means reducing or eliminating the barriers so that extra effort and help is not needed amongst particular groups for access. And so that's really what we're trying to achieve at this point for COVID-19 vaccination, equity. And that means inclusion of historically underrepresented groups, not targeting. And that means certain groups should be expected to receive more rather than other groups in order to achieve the same outcomes. So in terms of COVID-19, I think that the government and groups should expect to expend more effort and funds for communication and distribution of the vaccine in areas that have been historically disenfranchised and underserved. In terms of engaging people of color, I just wanted to share some of the emails and conversations that I've had with community leaders and the need to get community leaders on board because they have questions as well as the healthcare community. So these are some comments that I have shared from a Black nurse, a Black community-based health organization leader, and an Asian reporter. So there's concern about forced vaccination. You hear about if you don't take the vaccine, you'll go to jail. About the speed of vaccine development. Why did it take so long for other vaccines to be implemented in society, but the COVID-19 vaccine, less than 1 year even? This raises a lot of questions in my mind. And about vaccine trials, AstraZeneca had some setbacks early on. Does that make you worried about the safety of the vaccine? And then of course, this idea that I shared earlier, a need for personal connection and a feeling that people like you would accept the vaccine. So would you allow your child to be one of the first to be vaccinated with this vaccine? So these are things to think about how we will demonstrate empathy and respond to these questions in a way that is culturally relevant for each person. Another thing that I don't think has been thought about as frequently is the nuisance side effects. And I think it's really important for us to anticipate what may be future concerns amongst the public that we won't actually know about until the vaccine is actually being taken by a lot of people. So the Pfizer vaccine trial participants have reported fatigue and headache, and amongst Moderna vaccine trial participants, fatigue, muscle ache, joint pain, and headache. And from what I understand, these side effects are more severe than they are with other recommended vaccines. I'm told that it's similar to the Shingrix vaccine in terms of the severity of side effects. And that's really important to anticipate that and to be able to talk about that and allow people to anticipate that. and have a way to address that and tell people that means that the vaccine is working. You should expect these. It doesn't mean that the vaccine gave you the disease. That means that the vaccine is actually doing its job. Lastly, I think we need to think about vaccination mandates. You know, I think unless we do an excellent job with the way that we communicate about vaccines and really improve uptake, at some point, people will be talking about mandates. And that really is a double-edged sword. Vaccination mandates are super helpful in schools. They have really increased the number of children who have been vaccinated, but it's really important that vaccination mandates are used to maintain, not establish the social norms, because as I showed earlier, people are very afraid of being forced to vaccinate or forced to get a test. But the reason why they should be considered is they are a cue to action. So when people forget to go to the pediatrician, when the school is another reminder telling people, oh, you need to get this vaccine, that's something for another sort of safety net for, especially for people who are medically underserved. So in considering vaccination mandates, it's important to educate the population first and make sure that the majority of a population actually wants to receive the vaccine before instituting a mandate. And then lastly, it's important that there's fair distribution of burden and benefit for vaccination mandates. So we saw an issue with HPV vaccine when DC became one of the first jurisdictions to have a school vaccination mandate, and our rates were no higher, and people were very suspicious because we were a predominantly Black city. And so, you know, if there's going to be vaccination mandates, we have to make sure that they're not affecting communities of color exclusively. And that's all I have.
All right, well, thank you, Dr. Fu. Next, we will like to hear from Dr. Dawson about the plight of the nursing workforce. Especially because recent data indicate that African Americans accounted for nearly 37% of COVID-19 associated hospitalizations, and central to the mission of NBNA is diversifying the nursing workforce. So can you tell us about this important work you're leading in this space? Oh, you're still on mute, Dr. Dawson.
Okay, sorry about that. Before answering your question, I'd like to just give some background on the National Black Nursing Association. You stated the mission, but I would just like for people to know that we have about 114 chapters in 35 different states and also the District of Columbia. NBNA has over 4,000 members. 74% of our membership are made up of RNs, registered nurses, 3% LVNs and LPNs, and we're different from a lot of professional associations in that we also have students in our association. So we have about 23% of our membership is also made up of students. And 86% of our membership practice in hospitals. So this pandemic is extremely important to us. And 87% of our members also have either a master's degree or a doctoral degree. And then 13% are what we call nurse practitioners, which are providers of health services, and also nurse anesthetists. And so some of the things that we're hearing from our membership on the front line at this time, actually, I'm going to break them down into several different issues. The first one, supply issues. And this had to do early on in the pandemic when nurses could not get the protective personal equipment that they needed. And now with this second surge, we are experiencing the same thing. And even if hospital has the supplies, they're trying to monitor how they're releasing those supplies. And it's really causing a concern for the nurses at the bedside. And the next issue has to deal with ethical issues. Nurses are educated and trained to take care of people and to try to save lives. But with the limited bed capacity and sometimes limited ventilators and other life-saving equipment, they're being expected to participate in making decisions that are both moral decisions and ethical decisions, such as how long will they run a code, how long will they give a patient CPR, or when families cannot visit. They're very used to interacting with the family and supporting both the patient and the family system. In this case, they're having to be that sole support for patients that are dying, because many times the families are not there at the bedside. Then there's the safety issues relating to themselves and their extended family. Many of them are concerned about, can I catch this disease? When I get the virus, do I take it home and then I spread it to my family? And we have had members that have died from this. For example, back in the spring, we had one of our nurses who lost a daughter who was a teacher. And then about 3 months later, she herself expired from COVID. And so along with the safety issue come the self-care issues. And nurses are experiencing burnout. They're getting physically tired. They're mentally tired. And again, they're in that situation where we're really expecting for them to have some post-traumatic stress syndrome, because they're seeing patients just dying. I remember one nurse that I spoke to, and she said, I think I may have to get out of nursing. Within the last 2 weeks, I've had 10 patients to die. That is a lot of death in a very short period of time. And then the professional issue. And the professional issue really is a global issue. It deals with the lack of direction, the inconsistency in support, and the lack of nursing resources. And when I say the lack of direction, we know that we have always said that we had one of the best healthcare systems in the United States. However, I want to put an S on that. We have the best healthcare systems, and multiple systems really does not work well when you're talking about a pandemic, because you need to have some level of collaboration, cooperation, and someone need to be given direction. And maybe not just one person, but there just need to be some coordination. If I give you an example of what I'm speaking of here, if the United States was at war, somehow our military would respond effectively. We have at least 4 different branches. We have the Army, they will know what to do on the ground. We have the Air Force, they would know how to attack from the air. And then we have the Navy and the Marine. But somehow they would coordinate the efforts with a focused purpose. And we have not seen that with this pandemic. There's been too many misdirection, misinterpretation, wrong information getting out to the public. So that's why people are afraid, because we've been so inconsistent. And that is also a frustration for the nursing profession, because not only are they going to be asked questions by the patients and the families they're taking care of, but again, these are trusted individuals within their community. So they're going to have a faith-based organization referring to them, their neighbors, their family members, and how can they deliver a consistent story if the directions that they're receiving happen to be inconsistent? And then there's the staffing issue. So some nurses are being deployed to work in areas that they were not necessarily trained in. Yes, we receive global education when we're in school, but once we start practicing, because of the diversity of patients and the way hospitals are structured, they're always going to be working with different patient population. Some are going to be in the ER, the OR, inpatient services, outpatient, medical surgical units versus ICUs, and then those intermediate units between the med surg and the ICU unit. And so with that, again, asking nurses to offer for a certain, and I know we've tried to train them up, so I think the hospitals have tried to do a very good job of giving them just-in-time training, but that is exactly what that is, just-in-time training. And so you're still asking people to step outside of their comfort zone. And so along with that is also aligning the issue related to travel nurses. So when we had the hot spots like Miami, New York, Connecticut, Chicago, and some of the other areas, we actually had travel nurses leaving from one state going to another state. And so nurse migration is good. It was helping out with the pandemic early on. But now, as we've seen all 50 states have a big surge going on at this time, the nurses that may have traveled usually contract to stay in that state or at that facility for a period of time. So now their own home state is understaffed. So we have to look at that demand for nursing resources and how do we tap into those resources. And I think the nursing profession, we're trying to be creative. We have some people that are willing to move from academia back to the bedside. We have some states that are relaxing their laws so that retired nurses that retired in good standing can re-enter the workforce without delays. So there are things that we're trying to do, but yet still, we all need to appreciate those frontline nurses and understand that really, as one of the nurses said, I've been sent into combat, but I just don't have the equipment.
Thank you, Dr. Dawson. It's very powerful. And I want to remind folks that we will have time at the end of the panel for questions from the audience, so please do hold those and keep them in mind. So lastly, and not least, we'll hear from Dr. Sandoval, who's developed a successful model for conducting community-based clinical research. So Dr. Sandoval, we'd love to hear about your journey and your insights on the importance of diversity in clinical trials.
Great. Well, good afternoon, everyone. I'm very pleased, honored to be asked to be a part of this presentation discussion. The two co-panelists are incredible, so thank you for letting me kind of finish up this presentation. So what have we been doing? So Emerson Clinical Research Institute was started almost 7 years ago. We are in community-based locations. I started off actually in Southeast and moved our practice to Northwest DC. And we work with a lot of partner organizations. We actually work with a large federally qualified health center here in DC called Mary's Center. We work with 2 ophthalmologists in Falls Church, vision consultants and surgeons and retina specialists of Virginia. And then we started off our own community practice afterwards. My main focus has always been clinical trials. And I left the work that I was doing at a large hospital in Northern Virginia because the patients that I needed to treat and help out in clinical trials weren't going to the hospitals. And just through anecdotal evidence and of asking individuals, why not? Why don't you go to the hospital? The answer is, no, of course I don't trust. And number 2, I don't have the money. So most research takes place at these major institutions. So I decided to take the research to the community settings. We have a very humble building, but that's where our people are, right? I think what Dr. Fu presented and said about the urban communities and multi-generational families, that's exactly where we are, right? And those are the patients we're actually trying to help. My staff is a multicultural, multilingual organization. Everyone speaks at least Spanish. We understand kind of the cultures that we're trying to address, and we're in the community all the time. We do a lot of outpatient, all of our treatments are, clinical outpatient studies. But more importantly, we started a foundation. We started a foundation because we started to work with consulates as well. So we actually have staff that work within the consulates to educate patients. So I know you have all gone to the DMV and sat around waiting for your driver's license to take place. So instead of sitting there just playing with your iPhones, we have someone there that talks to you about your health, right? So the consulates, we're in front of them, explaining to them what's going on, what health conditions they have, and then we do screenings. And then we do a lot of screenings of either a study-related screening or just a general health screening. And we partner with other organizations so that they can come and give talks. Because of this, we were missing one piece, which was the community clinic. So we had patients that we were educating, but then there was nowhere to dump them because our partner clinics were already full. Same thing with the research patients that we were doing in conjunction with our partner clinics. once if the patient was not part of the community of that FQHC or a clinic that was associated and they were done with the study, they were done. So we started a community clinic to do that. So we did it backwards. And now the three organizations, the Research Institute, the community clinic, and the foundation all feed each other, patients and education. And we take uninsured patients. We don't take insurance, number one, because I started this practice, research practice, not with the intent to get rich, but to educate and provide research services. And honestly, trying to figure out the billing system for insurance is a nightmare. We tried to do it for a while and they said, you know, forget it. So how much do we get reimbursed? It's $100. Fine, let's just charge $100 to the patient, right? So super cheap. We were able to get really inexpensive prices for labs through Quest. And we've grown that. Patients come to us from Baltimore, Annapolis, West Virginia, Manassas, Woodbridge. I live in Woodbridge, so I know it's a hike. It's an hour-and-a-half drive for me, but it's important. So patients come from everywhere. And the other reason why they're coming from everywhere is because we've been fortunate enough through our foundation to start a TV show. So we've been doing my TV show now for 2 years. Actually, in January, we'll start year 3. We're an Emmy award-winning TV show where we talk about healthcare. It was amazing that we actually beat out a bunch of other real TV shows and real stations, and now we're a real show. Right? We have 60,000 people that watch us every Saturday morning at 11:30 a.m. And if you don't watch, watch. Right? It's a great show. Practice your Spanish. And we talk about everything. We've done 18 shows on COVID. We actually did, I'm glad you guys mentioned that you have your program on you know, these fake drugs that are coming out, right? You know, NCL has this program with that. We actually, the FDA asked me to do a show on that as well. So we talked about issues with what are real medications, what are not, why are people going to the grocery stores to buy penicillin? Why are they going to the grocery stores to buy injectable B12 with ibuprofen mixed in it, right? Why are they doing that? Because they have nowhere to go. So I say on the TV show, we can all wear a lab coat, right? The butcher wears a lab coat as well, but I don't go buy my medications from the butcher, right? And I don't sell meat from the butcher, right? So I'm educating the patients to stop buying junk from these locations. So that was a great TV show that we did. And part of that is because we have a relationship with the Office of Minority Health from the FDA, right? We have a lot of interactions with major organizations. So with the FDA, we also have John White, the Chief Medical Officer from WebMD, is part of our advisory panel for the TV show. From the National National Hispanic Medical Association, with the National Institutes of Minority Health and Health Disparities. So we have all these individuals that kind of feed us information so that we can go out to do more education. Next week, I'm interviewing Dr. Han from the FDA to talk about what's going on with COVID vaccine. Our mission continues to educate, continues to bring people in, and trust. We are establishing a true level of trust in our community because the work we do with the consulates, because of the work we do with the TV show, because of going out to do health fairs. Now we're kind of stuck, but we're still trying to do some health fairs that way. Because we tell patients from the moment they call, say, don't worry, I don't care if your legal status, I don't care about your insurance status. No one's gonna get your information but us. Gracias. That's what they need to hear and get that level of understanding. We open early, we stay late, we open on weekends. We do a lot of things to accommodate our patients who have no access. In our research studies, we provide transportation for them. I fight very hard for pharma companies to say, please give me extra funding so that I can bring these patients to the clinic and back home or back to their place of work. That has really increased our ability to have employee retention and not employee, yes, employee retention as well, but patient retention and patient satisfaction has been tremendously appreciated because of that. So that's the kind of stuff that works for us. Doing these little things, giving them snacks, giving them a car, giving them a place for them to have their kids, showing that level of trust, being in the community has really worked for us. We've done all kinds of work, and because of that, now is that we need to say to the pharma companies, don't just say you have a diversity program. Don't introduce me to the vice president of diversity affairs. And then when I talk to the vice president of diversity affairs with the large pharma company that I know, and I say, wow, well, how big is your staff? This poor individual said, it's just me. That's not putting your money where your mouth is. That's just putting a facade. If you're gonna do it and do it right. We're successful because the people that I bring on board in our research sites are dedicated and they see the need for our own people to be in these studies. Some pharma companies, Genentech is doing an outstanding job, right? They're pushing this issue. They have large staff focused on diversity in clinical trials. And I say that not just because they are one of our TV show sponsors, but because I really have seen the difference. I've seen what they're trying to do. So that's what we need to do. Sponsors need to take this leap forward and do it. Because it's the right thing to do. There's no mandate that says we have to increase diversity, right? There is this great scarlet letter that I love from the FDA called the FDA Snapshots website, which I'm gonna share with you so we can all look at this website if you've never seen it. So we're gonna go live. We'll go onto the web together and we'll surf this. So let's see if I can share my screen. Share. Oh, okay. So do you guys see my screen? Okay, great. So very easy. You can just go to the FDA Snapshots website. Just type in FDA Snapshots. And here you will see what are the last medications that the FDA approved. And if you've never seen this website, I love it because everyone, this is through no fault. I'm not blaming anyone and I'm not saying good or bad. It is what it is. I hate that sentence, it is what it is, but in this particular case, it's really true. We can't blame the pharma companies. The pharma companies try to find the right sites, right? Sites are trying to find the patients. We will get paid the same $10 no matter what color your skin is, right? Some sites are just not able to find these patients because they're not in the right communities. But we need to push that information out. So let them know this is the reality, right? So let's look at this. This is a great one, right? So I just organized these by year of approval, right? October 22, just came out, COVID treatment. So let's look at it. It tells you who the company is and what they've done. And then just literally, I don't need to read all these fancy words, right? Okay, so if not reading, let's just look at pictures. I am very impressed when I saw this, right? So demographics, it says, 37% women, 40%, 63% men. I find that particularly interesting. A lot of times it's mainly women that participate more in studies than men. In this case, it was off skewed, right? So it shows that amount of patients. I love it. So this is great. Look at this. Caucasians, 57%, African Americans, 18%. And then we have Asians at 14%, 1% Indian, and here we have 9% other. I'm assuming 9% other is probably Hispanic, right? This is beautiful. This is a beautiful result, and I'll show you why in some other cases. It talks about the age difference, right? So this is great on age. Great, this company did a nice job. Here we look at Hispanics and Latinos, right? Just by ethnic background. So the one that was other, you would probably find here, right? So once again, nice numbers. So good job to this one, okay? So let's just do it again. And one that I looked at here, acne. So I did this acne one. Right, and I can tell you there's lots of people that I see in my clinic that have with acne, right? This is pretty well split, on that, but now look at this, dun, dun, dun. 90% white, how come? I've seen Hispanics, I've seen Asians, I've seen African Americans with acne. Why weren't they enrolled in this study? Not sure, right? It was a big study. We see the ages and, the rest, right? Hispanics, about 14%, non-Hispanics, 86%, right? So I call it the scarlet letter because you can see the reality of what's happening. we can call these sponsors and say, hey, why didn't you bring more patients in, right? And then they'll say, well, we're trying to do another one. Now, the FDA will still approve these. Now, there's some medications where the FDA is now saying, well, show us what efforts you're putting in place to try and increase diversity. So if they put in place a plan and say, this is the plan we put in place, this is what we did, right? So I encourage you to look at any of these on your own time, just to get an idea, and look at your own companies to see where they are on here. Whoa, look at that. Lots of women, must have been a female study. This is nicely split. So I show it to you. So it is a good example as to where the industry is moving. It's a work in progress. The FDA really works with sponsors to try and make this change. I think sponsors need to really get on board and make this happen so that when their study is approved, they have that kind of, personal gold seal that says, look, we were able to do it. And it happens because they're reaching out to the right sites. They need to do, when they do feasibility questionnaires, indicate what is the population that you're looking for. And then sites, so I also, I am on the leadership council for the Society for Clinical Research Sites, right? SCRS, over 30,000 sites across the country that we talk about this issue. And I've had now Genentech and Merck and Pfizer and Janssen all have in their feasibility questionnaires information that says, do you recruit minority populations? How do you recruit? What is your plan? Because they want to see that. And we said, but please don't, punish us because we don't have these plans in place, right? We're great, right? My site, that's all we do. It's 100% diversity, but it's because that's how we started the company from the beginning. Other sites don't have that luxury. So we need to help those sites develop that luxury to increase this portfolio. I've been blessed because I don't sleep, and we started the foundation and started the TV show, and we do all this other stuff. And just so you all know, it doesn't take a lot. If you are able and willing to support our nonprofit, please support our nonprofit because we need the help to do this. Let me show you how cheap it is to do a TV show, right? Check this out. So from the background that you see, my pretty background, that's where I do my stand-ups. That right there is where we do our other stand-up. That's where we stand and talk about what's going on in health. That is my team's meeting room when we're just having staff meetings. And that other thing over there is where I have my plasma screen TV where I educate patients. And then of course I have a green screen. And that's it. That's all you need. Please go visit our website so you see what the TV show looks like so that you know that if someone really wants to make something happen, you can make it happen. You don't need a lot. You just need that drive to make it happen. And I've been blessed to have the right people in place. I'm always nervous because we may run out of funding for the TV show, but we have the research. Our goal is to do research. Our reporter is now in Florida and does great work finding patients. We're out there. This is what we need to do. We need to educate all the time. I think the information that was provided to us in Dr. Hunt's presentation that talked about people not having access or being aware, that's what we need to break. We need to break all those barriers because people are right. You're not going to go to jail if you don't get the vaccine study, but people think that. Our people don't even know what a refill is. What does it mean to have a refill? They don't know. So we have to educate on that. So with that, I will leave you to say we have been pushing diversity in clinical trials for 7 years now, and I'm going to keep going, and we all need to do this together as a team. I am extremely proud to be a part of this presentation. I think NCL is a great organization, and you guys have Jet as an amazing person on board. She is going to, you're so lucky to have her there. I love her to death. She is fantastic, and she actually met me before I even started this whole thing when it was just myself walking around with the business cards that I kind of developed on my own, I think at home, and look where we are now. So thank you, Janet. You are fantastic, and thank you, everyone.
Oh, thank you too, and thank you for sharing your journey and talking about your work. Yeah, I was just saying that it's always so great to hear from you because you really do come across as your passion for this work and your vision. So thank you. Since this is a really small group, we can actually open it up to folks for questions if folks have any questions or comments for our speakers.
I call Dr. Han instead of Dr. Fu. Can you believe that? I just realized I misused her name. Sorry, Dr. Fu. Sorry. Because I was
No
thinking
worries, I respond to anything.
the commissioner one day.
Yeah, so we know that, you know, consumers are worried right now, or we're actually worried about how we're going to educate consumers about the availability of the COVID vaccine, right? And there are a couple of things that, you know, we are battling, the uphill battle of the way it's been politicized. But, you know, there are a number of things that Dr. Fu pointed out. And so I don't know if we want to hear from Dr. Dawson about, and then also maybe Dr. Sandoval already about how or any recommendations for how we can, you know, improve education on vaccine confidence to help this uphill battle we're about to embark on.
Well, I'd just like to share that back in October, we actually started the Black Coalition Against COVID-19. And that is a group that consists of the presidents of the 4 historical Black medical schools, which include Morehouse, Howard University, Meharry University, and Drew out in California. And in addition to that, we are also working with some of the scientists that are working at Pfizer and AstraZeneca, and bringing those in along with nurses, and we are coordinating this also with the Urban League and the National Medical Association, and so we are trying to bring together the voices of African Americans physicians who are in that space and others, so that we can become the voice and we can get the word out to our population. So I would say to date, we probably have had about 5 different events. Some have been radio conversations, some have been Skypes and Zooms and just Facebook. But I would say at this time, we've already reached over 1 million individuals. And so I think we're going to have a great impact with this group working collaboratively in terms of trying to answer some of the questions that are out there. So we're not just speaking and giving a lecture, but we're actually just opening up a conversation and try to answer some of those questions that Dr. Fu mentioned earlier about the hesitancy. And one of the things that I'm trying to do personally, I really don't like that word. So I try to use it as less as I can, because I think words have a lot of meaning. And sometimes we can plant things into people's mind that they're not even thinking of. And I think people have a right to be cautious. I don't tell people, yes, everything is going to be fine. That's not the message that we're trying to get out there to them. But we're trying to say we have to look at, so for example, when someone say, so why are you developing this vaccine faster than any other? Because during my lifetime, we never had a virus or disease that is killing as rapidly as this one. That's real. That's something they can understand and something they can deal with. So we don't have the luxury of waiting for 8 years. If we are losing this many people and the year is not over with yet, multiply that by 8. And so we just have to be real and have a true conversation, I think, with people. When they ask questions, don't dismiss their fears, you know. So one of the things we do know, and Dr. Fu pointed that out very clearly, almost every population have a high trust in individuals that look like them and live in their communities, work in their communities, go to church with them. Their kids play with each other next door. They're in the same school system. So, and they understand some of the adversities that that population has gone through. So you build that trust relationship over time. It's not something that all of a sudden you just jump up and you have it. So for example, when we talk about why we don't have as many African Americans participating in research, it's not only because of some of the historical missteps that we made with research in the past, but it's also because we have been extremely limited in participating in the American healthcare system. So if I can't get access to regular care, why should I come and help you develop your science and I may not even be able to benefit from that science. Now, I know these are some hard things for people to accept, but that's the truth and that's the reality that we have to deal with. And if we don't address these issues and concerns by at least being transparent, then we're going to continue to have problems and continue to have issues. And I know some of the studies that have been out there and surveys, there's about, at least, 1 out of 3 African Americans that say, well, if this pandemic had been affecting and killing whites as fast as it's killing black, the response would have been different, So again, that's a reality. And when people have a perception, we can't argue with their perception and try to get them to see something else. We have to meet them where they are and hopefully keep saying, but we do have scientists that are out there. And on one, for example, on one call I had, someone asked and said, so have you had the flu shot this year? I said, yes. As a matter of fact, my primary care physician was very proactive. She told me to take it back in August and said, if I need to repeat it, then repeat it. But I've also had the shingle vaccine. And one of the things that I will say about the National Black Nursing Association, community engagement and working in the community, that has been our hallmark since our beginning. And next year we will be celebrating our 50th anniversary. So we've been around for a long time. But we have a community collaborative model that we have practiced all along. So when this pandemic hit and our nurses started getting on the radio, doing Zoom, out there going door to door, checking on people, no one was saying, so who are you? Actually, they was calling on us saying, we need the Black nurses. We trust you all. You come to our health fairs, you visit our schools. And then we was blessed to have relationship with a lot of the companies that are developing this vaccine. So we was working with Pfizer because we was, again, looking at the flu vaccine and the pneumococcal vaccine and the vaccine for the shingles. They were coming in doing educational sections for us. AstraZeneca, we know these people by face. And now when they're talking about how they're going to roll this out, we've been working with CVS. And trust me, if we had not been working with these individuals prior to this pandemic, we would not be trying to partner with them during the pandemic. So relationships are extremely important.
Well, if I might, since you've mentioned pharmacy, you kind of set my fire. I'm Ernie Boyd. I'm with the Ohio Pharmacists Association, and I'm so glad to hear all the information from all of you. It's interesting. I've got the September 28th copy of Modern Healthcare magazine in front of me. This is Nadam Ahim, who owns an independent pharmacy in Dayton, Ohio, and was put on the cover because he is part of a program we have in Ohio to expand pharmacists into provider status, where they're now being paid to interact more thoroughly with the patient and to make sure that they're using the medications properly, getting the drugs. You probably know 1/3 of prescriptions are never filled. And so the insurance companies are working directly with us to do screenings, to interact with physicians more. They pay us to have agreements with physicians to manage and modify drug therapy. And so I just mentioned that because in COVID, I've been told by my pharmacists that the #1 question they're getting right now is about the vaccine, as you might expect. Our members will be administering the vaccine soon. I just got notice from the governor's office about how the distribution in Ohio is going to go. So I do suggest that, in any way you can, if you can work with we have 310,000 pharmacists throughout the United States. And you mentioned CVS. We have a lot of great chain pharmacies, but don't overlook the independent pharmacies who tend to get involved with the patient a little deeper. And that's no shot at my chain folks, but sometimes time pressure doesn't allow them to get involved in the clinical activities quite as much. That's about as far as I want to go down that path. But just expect that pharmacists can give you the education backup. And the thing about Nadam is his pharmacy is representing what you're talking about. He's in a very, an area of Dayton that is very challenging. The mayor, when I was on a panel there a couple of years ago, credited him with bringing back a 2-block area of that city. So I think there's a lot of great things you can do with pharmacists if you reach out to them.
Okay, thank you.
And I think that's a wonderful suggestion though, right? Because pharmacists speak with patients perhaps more regularly than primary care providers because they go to get their prescriptions. And if it's the same person that you see in an independent pharmacy over and over again, you're bound to develop a relationship. It's the type of relationship where patients are used to receiving advice in that setting. And what the CDC recommends is talking about vaccination early and often. And so providing training for pharmacists early on how to provide a strong recommendation will be important in addition to considering how to train doctors, nurses, and ancillary healthcare staff in how to provide strong vaccine recommendations.
I'll say one last thing. Sometimes we do feel like the Rodney Dangerfield because we're kind of left off to the side. But a number of people equivalent to the state of Ohio come through our doors every week. The pharmacist is the most known of all the professionals. We're the only one you can walk in and talk to at midnight and not pay a fee so far. So anyway, I just open it up that our guys and gals are more than willing to take a greater role. But a lot of times, and I know with insurance companies especially, they haven't looked at it. They are now, but because we're moving the needle in terms of patient care.
And we really, the National Black Nursing Association, we have a very interprofessional approach. So our local chapters are actually encouraged and allowed to have members from other professions to join as what we call affiliate members. And so in some of our local chapters, we actually have pharmacists that are members. And again, many times when we are putting on in-services relating to drugs and those type of things, they are the ones coming in and helping to provide that in-service at the local level. When we're having health fairs, we try to have them there with us. I know one of our chapters partners with a physician that goes out to the rural area. And when they go out, our nurses go out, the pharmacists are there, the dietitians are there, and they even have the volunteers they're giving away clothes and cooking during the event. But the physician actually have a mobile unit. And while she's doing exams, others are doing educational sessions, and the pharmacist there helping to provide free drugs and education on drugs. So we definitely, when I say collaborative approach, I truly mean a very collaborative and interactive approach across the professional span.
I have to one. I left my information on the chat group just in case. They're calling me. I've got some patients I have to kind of run see. So bless you all. Stay clean. Thanks again, and hopefully we'll be in touch. Ciao.
Thank you.
Leave me alone.
Thank you. Sally, did you have a question you wanted to pose and so you put it in the chat?
I put a few questions in the chat box. I'm interested in knowing from our healthcare providers that are part of the panel, whether you feel comfortable encouraging your patient populations to get the vaccine when it becomes available. There's been a lot of concern about the politicization of the vaccine. We have done a lot of work with the FDA and other the healthcare professionals within government and certainly in the private sector, trying to determine and ensure that these vaccines are being given every consideration, very, very closely monitored, reviewed for adverse effects and safety and efficacy. I'm curious about your patient populations and whether you feel 100% confident yourselves and how you are communicating that to your patients when they come back and raise these very important questions.
I don't know if you're talking to me, but I'm happy to respond.
Oh, you and Dr. Dawson.
So it is an interesting, difficult question just because it's such a need, but then you can't rush people into making a decision that they're not comfortable with. Like I said, I'm on the one of the stakeholder advisory panels for DC Health in how they're rolling out their communication and distribution plan, and then also for our hospital. And so that's how I've had some interactions and hearing what people's concerns are. I mean, I think the most important thing, like back when they had the polio vaccine and the MMR vaccine and everything, right, is showing people in leadership roles accepting the vaccine, which is why I think it was so important for the presidents of HBCUs to enroll in these clinical trials. And so what I've said to people is that I will feel very confident in the safety and effectiveness of these vaccines after it undergoes FDA review and approval and ACIP review and recommendation, because I trust those independent boards on both the FDA and ACIP to make a non-political recommendation. And I think a lot of people aren't familiar. I mean, there's been no real reason for people to be familiar with the drug approval process. And so, you know, one of the questions that I had put up there from somebody was about, you know, AstraZeneca having quote unquote setbacks. And so people not understanding the role of independent data and safety monitoring boards to review that data and the chance for, you know, people, you're involving tens of thousands of people in trials. They don't understand that you start with a smaller number and then increase to larger numbers. I've had that question as well, like why did they start with smaller numbers? So just illuminating that process, and as Dr. Dawson said, really providing transparency is important in letting people arrive at the decision on their own after providing all the information in terms of the independent reviews, multiple independent reviews in this country that are going on. To those who are worried about the politicization in this country, you know, I think it's great that the UK jumped in front of us and have approved the vaccine, the Pfizer vaccine there. So I point to that as well. Like if you're worried about in this country, the UK did that. Of course, Dr. Fauci, who is always on, and you know, you could, bless his heart, he constantly has to be correct, but he did set that back a little bit by saying perhaps they rushed it, and then he walked back his statement. It's really important what we say. Every little thing can be taken as you know, doubt in lack of confidence in our process, and that's really at what's at stake right now. Confidence in our independent review process, and the more transparency we can provide about that process and about the outcomes, including negative outcomes, is really important, and anticipating what concerns may be.
For the National Black Nursing Association, we are fortunate that we've had nurses working with vaccine and doing some of the research, but also out in the community for a long period of time. So one of the things that, and we also have nurses that are participating in the clinical trial. So it's good when you can talk to someone and you let them know that your own membership is involved in this process. But again, that's why I was so excited when Dr. Reed Tutson contacted me and said, Martha, will you come to the table with these other individuals that I just named, those historical medical schools, because they're all right in the, I would say, in the center of this. So they're doing some of the research. There are going to be sites where people can come and get the vaccine. So I think that is extremely important to have individuals that are not just there as the president of the university, but they're guiding some of the research activity, they're monitoring those things. Now, one of the things I think we're gonna have to be able to answer very clearly is, I think I was looking and I saw someone put in the chat box about how you're gonna get people to come back, you know, for that second dose. I think that's where we're going to really have to begin to step back and not just focus on policy, but also procedures. And one of the things that I know I have two nurses that are sitting on the HHS task force and with vaccine, not the COVID vaccine, but I mean, they're talking about COVID, but it's not that task force. This is a smaller group of actually frontline individuals who are discussing these type of issues. So if you're going to have someone to go in for that vaccine, are you asking people, we're telling them on one hand, we want you to social distance, We don't want you on, the buses and in the subways. But if you're asking someone in to come in early during this phase to get vaccinated, but that's the only way they can get, that's going to be a problem. So we're having discussions such as you have to push this out to the federally funded clinic. You got to move to the primary care physicians. And yes, the reason we're excited about CVS is because we know that CVS have nurse practitioners there. So if something goes wrong, they can at least go back and work with CVS to be able to do that. So it's going to be extremely important that we know that we're not going to discover every sign, symptoms, and every side effect, okay? There are going to be some adverse events. We just have to make sure that these people are going to be able to get the care that they need if it was to escalate, whether they be connected to a hospital, another, walk-in clinic type of thing. But if we don't do this correctly, we know as soon as you have 1, 2, or 3 event and it get on the media and it goes in the negative spin, we're going to have to start all the way back over at stage 1 or 2 with the education and try to convince people that, yes, this is a safe approach. So we are addressing and thinking about those things.
Thank you, Dr. Dawson and Dr. Fu. Thank you guys for carving out time. I know you guys are extremely busy, and this is a really great conversation, and we really appreciate you sharing this, your insights with us. So with that, we'll conclude the panel version of the part of this gathering today, because we want to have time for our members to provide updates or give their round robin updates on what's been going on. And we see that our friends at the FDA Office of Women's Health had to leave early, so they wanted to share their resource with us on the recent conference they had on sex and gender differences in the use of CBD. That's also an issue that we are working on, and it's our health, it's part of our health portfolio work that we work in. Do we have any other members that want to give updates today?
Jeanette, I believe Dr. Chin had an update.
You're on mute still.
So Eliza Chin, Executive Director of the American Medical Women's Association. Thanks so much for organizing this fantastic panel. It was really amazing, illuminating. I think along those lines, we really want to try to figure out how we can get our physicians educated, because again, as you all said, the physicians are the ones that need to kind of convey that confidence to the patients to make sure that people do get the vaccine. So would love to be engaged in any future efforts. We are part of a task force that is convened to help disseminate information and putting out a social media campaign, again, to give the public confidence about these vaccines. A couple other things since I think we last met that AMWA has been working on related to the pandemic. One is an initiative looking at mental health for physicians, and we've titled it Humans Before Heroes. As you probably have seen in the news, there was a woman physician from New York who committed suicide at the height of the COVID pandemic there, related to a lot of strain from treating patients with COVID, having COVID herself, and being worried about seeking care because impact to her license. And so one of the big efforts is, seeing how we can get these medical licensure and credentialing questions reframed so that physicians don't feel prohibited or discouraged from seeking treatment. Another initiative is on caregiving, and again, that crisis in the US and probably also accentuated by COVID because more people are staying home and relying on family caregivers and the burden on caregivers. So we're doing some education among physicians that, in addition to taking care of their patients, to address caregiver needs and help find resources. So those are just two things I wanted to share with you. Thank you.
Thank you. Brian?
Yeah, hi, Brian Isaacs, a pharmacist and professor at the University of Minnesota. I think Sally Greenberg and I share a likeness for the Minnesota Twins baseball team, right, Sally?
That's right. That's my team.
When I was on extended sabbatical at Medicare in Washington, D.C., I met in the office a couple of times, and she had her hat and actually a baseball bat signed by the Twins. So I still remember that, Sally. So I just want to say that I thank you for the folks that sent me the chat. No, it's just a screening test that I have. Actually, it's my 7th COVID test I've had. Just because I work in the healthcare environment, and they all been negative, and so it's just, thank God, I'm knocking on wood. Right now is that right in the middle of the advanced planning for the vaccine rollout. And so both in Minnesota as well as Wisconsin, because I also serve patients in Wisconsin, we're at the point where we're about to get the supplies within the next 2 weeks. As soon as the FDA gives the use authorization, it's go time. And so all the logistics are coming together. And so being a nursing home provider, fortunately I'll be at the front of this. And people ask me, Brian, are you going to take the vaccine? No questions asked. I mean, I see the presidents are going to roll, or past presidents are going to roll up their sleeves and do this on television. I tell folks, don't overthink it. Take the first one you can get. And then I think once we do get that first one, Sally, I do believe that when you get that individual for that first vaccine in, that's that unique opportunity to bring them back for that second one, because it's so important for the health of our nation. What I am concerned about are the next 2 steps down the road is the mask wars, which would be a second surge. Okay, I had my COVID, I don't have to wear a mask anymore. Well, that doesn't hold water. All right, and then we also have we're going to have to think about really what comes next and who's prioritized. All right, because some people may not get vaccinated until June, July is a possibility, because we don't know how this is going to roll out. So anyways, I'm working on national groups. I heard my colleague Ernie Boyd from Ohio. I'm sure he's up on top of this, but we in pharmacy are really working hard to fulfill our unique role as the frontline healthcare workers in each community.
Yeah, thank you. And before she left, Sophia Che actually shared the American Society for Health System Pharmacists resource on the principles for COVID-19 vaccine distribution, allocation, and mass immunization. So yeah, we appreciate the work that you guys are all gearing up to do. Thank you. Yeah, well, I think that we are at the end of our meetings. We've lost a couple of folks. Our speakers, our panelists had to go. Hopefully in June next year we could do this in person. I think that's maybe wishful thinking at this point, but you never know. Hopefully by the next time we meet, we'll definitely have some good news to share, and we'll be on the other side of this pandemic. Thank you all for carving out time. I know 90 minutes is a long time, so thank you for sticking with us.